Good afternoon, respected chairpersons, senior members of the faculty and friends. As the Buddhist saying goes, death is certain while life is quite uncertain. But we don't know the timing of our death. And sudden cardiac death is a disaster. What is the definition? It is the sudden natural death presumed to be of a cardiac cause, which occurs within 1 hour of the onset of symptoms, if it is witnessed, or within 24 hours of last being seen alive in unwitnessed cases. And after autopsy, a natural unexpected death of unknown or cardiac cause. 50% of all cardiovascular deaths are sudden. The problem is 50% of patients have this as their first manifestation. They just die. And SCD increases with age. If you look at the incidence in 100,000 from a child to the 8th decade, there is significant increase in SCD. We have various etiologies for this occurring at various age groups. What is shown above is the age group, 10, 20 and all those things. Males are in blue, females are in red. But you see the chunk, the biggest portion is acute coronary syndrome, starting from age 30 to age 80. Some of them have bimodal peaks, but here again, as age advances, it is coronary artery disease and dilated cardiomyopathy that is the main etiology. So how are you going to prevent this? We have to look at this under various perspectives. At an individual level, one person may come and ask you, am I going to die suddenly? There are certain high-risk groups where we have to intervene, which are common. There are certain high-risk groups which are rather uncommon and at the general population level. So our intervention should be in these perspectives. Let us take an individual level. A patient comes to you. You can have certain red flags in the history. Most important is a syncope without any prodrome, just fell down. It could be an arrhythmia. If there is a family history of premature sudden death, it may be just a car accident, it may be a drowning. Sudden infant death syndrome, deafness in the family, heart failure or use of pacemaker below the age of 50 years, it all points to a heritable problem. Cutaneous examination is very important. In sarcoidosis, one may see lupus as well as the erythema nodosum. In arrhythmogenic RV cardiomyopathy, we can see xanthelasmas and palmoplantar keratosis, Fabry's disease, angiokeratoma. A auscultation may tell you that this patient has got a mitral valve prolapse or an HCM. Then we usually take an ECG and we seldom look at the QT interval. We are always interested in the QRS and the ST segment, but QT is the most important predictor of a sudden cardiac death. Begins with the Q wave and ends with the T wave, what is shown there. If it is more than 450 in males and 460 in females, it is long. Less than 350, it is short. Both are equally important as a causative factor of arrhythmias. So it's important to look at the QT interval. Then you may see certain patterns like the Brugada pattern. Especially if you take a high precordial leads, this may be very manifest. Sometimes we just say that, okay, there is early repolarization, nothing to worry in the ECG. But some of these early repolarizations are actually malignant. What is shown in red? A prominent J wave which is slurred, a horizontal or descending ST segment. What is shown in red is actually they can lead to malignant arrhythmias. Elevated natriuretic peptides are now finding good correlation with sudden cardiac death. So it may also be used as a marker. Of course, after this, A cardiac panel of investigations may be needed like echo, exercise stress test, Holter, especially extended 3 days or 7 days, cardiac MRI, and finally genetic testing. Well, not possible in each and every individual, but if somebody is so worried, we may have to go ahead. Now let us take certain high-risk groups which we all deal with. They are coronary artery disease, a relative of a person who had sudden cardiac death, and a fellow who is incidentally detected to have an arrhythmia in a pre-op ECG. Acute myocardial infarction, sudden cardiac death is most often due to ventricular arrhythmia that occur within 48 hours is called early ventricular arrhythmia. Usually they are due to ischemia and they do not cause any long-term problems. No role for prophylactic antiarrhythmics. This has been the rule for quite a long time. We don't give antiarrhythmics to prevent an arrhythmia. Most important thing is do a CAG and revascularize the patient. That will take away the arrhythmias. IV beta blockers, if they are not contraindicated, may be given prior to PCI. There should not be any hypertension, there should not be any bradycardia, a class 2A indication. Even after your revascularization, if there is a ventricular arrhythmia, look whether your revascularization was sufficient. You can use IV beta blockers. Most important thing, look at the potassium, look at the magnesium. Very often we don't look at the magnesium. Correct them. They are the triggers there. Adequate sedation for an anxious patient. Still getting recurrent arrhythmias, one can use antiarrhythmics like IV amiodarone, lidocaine, deep sedation and intubation. Still getting, one may go for overdrive pacing, catheter ablation, autonomic modulation or mechanical circulatory support. Well, patient has come out of this. What about the subacute phase? Is he going to develop an arrhythmia? Higher chance if there is LV dysfunction. So our medical therapy for heart failure should be very, very optimal before the patient is discharged. That is most important thing, including beta blockers. The question is whether we should put an implantable cardioverter defibrillator, ICD, to save this patient. Well, we have to wait for 6 weeks to 12 weeks. As with the modern therapy, LV function improves in 95% of cases. If the patient develops an arrhythmia in between, one could do a catheter ablation, if possible, where they are non-responsive to medical treatment or revascularization. Or allow the patient to have a wearable cardioverter defibrillator for up to 6 weeks to 12 weeks. Especially if your revascularization was incomplete, there is LV dysfunction, arrhythmias are 48 hours after STEMI, if they are polymorphic VT or VF. What about chronic CAD patients? 6 to 12 weeks after a myocardial infarction, we look at the ejection fraction. If the ejection fraction is less than 40, that is the group that is going to develop arrhythmias. Less than 35 EF with class 2 or class 3 symptoms, indication is implantable cardioverter defibrillator. You keep the defibrillator inside, ICD. It's a class 1 indication. If the symptoms are only class 1 but the EF is still low, there also we may use an ICD to prevent sudden cardiac death. What about the ejection fraction between 36 to 40? We see whether there is NSVT or unexplained syncope. If it is there, you send the patient for an EP study, and if it's not there, medical treatment can be continued. If the patient develops a sustained monomorphic VT, there again ejection fraction is the most important thing. If it is less than 40, ICD. If there is a hemodynamic compromise, ICD, and no hemodynamic compromise, one could go for antiarrhythmic treatment. So that is the first subset, CAD patients in the acute, subacute, and the chronic phase. Ultimately, you can see all of them leads to ICD if indicated. The second group I would like to talk about is the relative of an unexplained sudden death decedent. Well, you look at the situation, non-autopsied sudden death decedent, whether they have done a genetic testing or not. If a genetic testing has been done and a pathogenic mutation has been found, it is easy, you go along that line. Otherwise, you look for family evaluation of the first degree relatives or relatives with suspicious symptoms. This already we have said, a medical history, examination, ECG, echo, exercise, testing. You may come to a diagnosis, still not there, Holter monitoring, cardiac MRI. Then you have to go for challenging tests like sodium channel blocker test or epinephrine test. Still, you may not reach anywhere, then keep them under follow-up. The third group is an incidentally detected ventricular arrhythmia during some other thing. Well, we have to evaluate them by an ECG, echo, as well as a Holter, if possible by a cardiac MRI should be done to rule out structural heart disease. Then there are uncommon high-risk groups like hypertrophic cardiomyopathy, arrhythmogenic RV cardiomyopathy and all. I will not be able to cover all this in this 12 minutes. This is a very good article. Whoever is interested can go through that. Separate chapters are there for each and every disease. What about general population who are without known cardiac disease? The most effective approach is to assess the coronary artery disease risk and modify them, as well as give public access to the automatic external defibrillators and teach them how to defibrillate, prompt CPR if there is a cardiac arrest, and community training of CPR or alerting a group who are trained in that. You may remember this film, Casino Royale, where even 007 just escaped because of a person who knew how to defibrillate. So public awareness about CPR as well as defibrillation could be life-saving. So to summarize what I have been saying, the most important thing in prevention of SCD is general management of the coronary artery disease risk factors. In an individual patient, careful history and examination may give you a clue. ECG is to be very critically analyzed, not just the ST segment. You have to have a look at the QT interval as well. Elevated BNP values is a red flag. In a selected individuals, one could use long duration ECG recordings as well as cardiac magnetic MRIs more often. If there is an indication for ICD, there should be no hesitation from our side in putting it in because it saves life. Thank you for the patient listening.
It was an excellent presentation. I think it was such a vast topic. As you already said that this is not a symptom of patient. We have to pick and find those patients who has got high risk in all the group of patients, whether it is coronary artery disease, whether it is cardiomyopathy or in other groups, valvular heart disease. We have to detect those patients who have got higher probability and we have to initiate the investigations and treat the appropriate treatment. If any questions from the audience, we can entertain one or two questions.
Holter, how do we select a patient? We need a high degree of suspicion, or is it we can choose a guideline or something is there for preventing SCD?
The choice will depend on how the person has come to you. If the person is related to somebody who had a sudden cardiac death, definitely Holter is indicated. We have to do that. But if somebody walks in and wants to have a cardiac assessment, we usually do not suggest a Holter unless his ECG is showing multifocal PVCs coming from various sites, or short coupled PVCs. So there are certain criteria in the ECG which could tell us that we need an extended ECG recording. Holter is just an extended ECG recording, so that we can see the burden of the PVCs. That is the concept that is now coming up. Previously, we used to say that, oh, these are ectopics, we can leave them alone. Now, if the burden is 20% of the total, these people are highly likely to go for cardiomyopathy. And even ablation is suggested. Even 10% can go for. So, Holter decision will depend on the individual patient. Supraventricular ectopics, no. So far, no guidelines have come for supraventricular ectopics unless AF is there or a flutter is there. No. Simple supraventricular ectopics, no guidelines have come.
So, thank you, sir.
Thank you.